I want to bring up our next speaker, Elaine Worrell. She is the director of pediatric epilepsy at the Mayo Clinic, but even more important than that, she has dedicated her life to helping kids like ours and adults. And every time I want to, complain about the medical establishment that we have here in the United States, I remember people like Elaine, who really are fighting every single day for a better future for our loved ones in their work, in treating patients with LGS, but in also their research to make it better. And she gives one of the best introduction to LGS talks that I've ever heard. So I'm very excited to introduce Elaine Worrell, and you're gonna love her. And if you live anywhere near Mayo Clinic, this is the woman you want your kiddo to see. We gotta clone you.
Thank you, Tracy, and thank you, Julie, for sharing Landon's story. That was so impactful. I think as a clinician, one of the things that always amaze me is just the passion and resilience of parents of children with the developmental and epileptic encephalopathies like Lennox-Gastaut, and I think your presentation really embodied that, so thank you for sharing. So I'm going to be talking a little bit about what we know about Lennox-Gastaut syndrome today. And here are my disclosures. So we'll first of all look at what do we know about the clinical presentation. Fairly recently, in the last 2 years, the International League Against Epilepsy put together diagnostic criteria for Lennox-Gastaut. In the past, we really didn't have those, and now we do. So we'll talk about that. We'll talk a little bit about how epilepsy evolves into Lennox-Gastaut, because most kids, as many of you know, at the time of your first seizure, they're not coming in and saying your child has Lennox-Gastaut. That's something that takes time to evolve. And then once you do have Lennox-Gastaut, as you kind of age, you become teenagers and adults, there's often changes there too over time, right? Changes in seizures that we see. So we'll talk a little bit about how that evolves. And then we'll address some of the underlying causes. And as you know, there's not a single cause for Lennox-Gastaut.
They can't hear you online, so would you mind using this microphone?
I will absolutely.
Sorry about that. Thank you.
Can you hear me now? Can everyone hear it? Okay, perfect. All right. So, and then we'll talk a little bit about the underlying causes and ask the question, how is it that so many different causes can actually lead to the same syndrome? So here are the diagnostic criteria that were published a couple of years ago by the International League Against Epilepsy. And as you can see, there's mandatory things you must have to make the diagnosis. There's what we call alerts, that if you have those, that should raise a question, is this really the right diagnosis? And then there's exclusionary criteria. If you have those, this is not Lennox-Gastaut syndrome. But here's the thing with definitions. So on one side, you see this basket of peaches, right? And they're all peaches. And then on the other side, you see peach-like fruits, right? There's a nectarine, there's a peach, there's an apricot. They're not all peaches, but they all have similar features to them. And that's the same thing with Lennox-Gastaut. There are people that we see that tick all of the boxes, and they're sort of I call them the pure Lennox-Gastaut. But there's another group of people, and they are not rare, that maybe don't tick all the boxes, and they are what we call Lennox-Gastaut-like, or I call them Lennox-Gastautoid. They still have significant medical need. They often have very similar features to the pure Lennox-Gastauts, and we think they actually respond probably pretty well to many of the medications and therapies for Lennox-Gastaut. And so we want to be sure that we don't kind of get over ourselves with really becoming a purist, and you have to tick all of these boxes in order to use the medication. So I think just to say that this is a bit of a spectrum. There are people that are pure, and then there's people that kind of are almost Lennox-Gastaut, and still I think we should consider them in that view. And one of the good things that's happening is that there has been a recent study, and the FDA approved this, to do a drug study in developmental and epileptic encephalopathy. And so for many of the families with Lennox-Gastaut, if you don't tick all the boxes, you don't meet criteria to get into the drug studies. That's not really fair, and so I'm really excited that we're actually now seeing at least the FDA and many of our industry partners interested in looking at this broader range of people. So we'll talk a little bit about how the ILAE has defined Lennox-Gastaut. And so to have pure Lennox-Gastaut, what you need are tonic seizures. And I think even people who have Lennox Lennox-Gastaut usually have tonic seizures. Tonic seizures can be more obvious with sort of stiffening of the whole body, typically arching of the neck, opening of the eyes, rolling the eyes back. If they are more significant and happen during the day, the person can fall down, usually stiff like a tree, so they are a drop seizure. But they often occur at night, and if they're at night, they can be quite a bit more subtle. And unless you're actually sitting there watching your child sleep, you're not going to see them. Because what they are is just a little bit of arching of the neck, opening of the eyes, and rolling the eyes back. Usually they're lasting a second or two. And then in addition, you have to have at least one other seizure type, and you can see here a pretty broad range of seizures: absences, myoclonic seizures, atonic or loss of tone seizures, generalized tonic-clonic seizures, focal seizures, and epileptic spasms. And most of our kids and loved ones with Lennox-Gastaut are actually quite generous and give us much more than just one other seizure type, right? There's usually many other seizure types over the course. In addition, as we all know, the seizures are drug resistant, and long-term there is associated intellectual disability that can range quite broadly from mild intellectual disability to more profound intellectual disability. And Lennox-Gastaut is something that always starts in childhood before 18 years of age, and in fact, usually before 10 years of age. On the EEG, there's a couple of things that I would look for as a physician. So there's something called generalized slow spike wave that we see. And then when the child goes to sleep or the adult goes to sleep, we see this pattern called generalized paroxysmal fast activity. So those are sort of the two characteristic features that we look for. And then other clinical features, so oftentimes there can be abnormalities on neurologic examination, and those usually reflect the underlying cause. And as we talked about, there's many different causes. And then when you look at the child's development, most children will have developmental impairment that precedes the diagnosis. However, as you all know, when your child starts having very frequent seizures, the development really starts to plateau, may even go backwards. Now, we had done a little bit of a survey, how many people had heard about infantile spasms, and there was a lot of hands that went up. And I think that one of the things that's really important is how kids evolve to Lennox-Gastaut. And this was an interesting study that was done by Anne Berg, and she looked at all infants with what was called developmental and epileptic encephalopathy. So that's a group of disorders, very frequent seizures, very abnormal EEG, and developmental impairment. And she had 58 of these infants, and at the time of their first presentation, she could say, yep, 4 of them had Lennox-Gastaut syndrome, and in fact, 1 of them didn't. It turned out to be the wrong diagnosis. But at follow-up, it turned out that 22 kids now met criteria. So we see that a lot of these kids can take time to evolve fully into Lennox-Gastaut syndrome. It can be a tough diagnosis to make with certainty early on. And she found that it takes, on average, about 1.9 years, so almost 2 years before the kids were able to tick all the boxes and be defined as Lennox-Gastaut. And furthermore, Lennox-Gastaut is actually a pretty common endpoint for epilepsies that begin in infancy. So somewhere between 13 and 19% of infants with epilepsy ultimately will turn out to have Lennox-Gastaut. So once you're defined as having Lennox-Gastaut, and then you're growing up, right? You're becoming an adolescent and then an adult. And what happens with time? So we often see that the number of seizures, as well as the variety, the different types of seizures, can decrease with time. So adults often have less seizures, not in everybody, but often have less seizures than they did when they were children. And they have a lower number of different types of seizures. What we typically see are those tonic seizures, those stiffening seizures. Those significantly decrease when the child is awake. And so in adulthood, many people no longer have those stiffening seizures while they're awake, but they're still there when they sleep. The other thing that we often see reducing are atonic seizures, those drop seizures where they lose tone. We often see a reduction in absences and a reduction in myoclonic seizures, but an increase in focal seizures. So sometimes that can make it a little tricky if you haven't had the diagnosis in childhood for an adult provider to say, yep, this is definitely Lennox-Gastaut. And we also see changes in the EEG. So remember, we had talked about those 2 characteristic patterns being present. The paroxysmal fast activity is something that stays in adulthood, but that slow spike wave may no longer be present in adulthood. And it doesn't mean that you no longer have Lennox-Gastaut. That's just how that syndrome or how the EEG evolves. So moving on to comorbidities, you might recognize these two partners in crime. And so what we often see is a lot of comorbidities, right, with Lennox-Gastaut. And for most patients, intellectual disability actually worsens with age. Looking about 5 years after Lennox-Gastaut onset, about 95% have variable degrees of intellectual disability. And when we look over time, we often see that patients will have a decline in their IQ by more than 15 points. In many cases, they're actually not regressing. They're not losing skills that they once knew, but they just are failing to gain new skills at the expected rate that you would see. And so the gap between them and neurotypical children widens over time. As you all know, behavior and sleep issues become very significant in many patients, particularly during adolescence. And this can be very impactful on quality of life, the hyperactivity, the autistic traits, the aggression, and the sleep issues. Long term, about 15 to 20% may have more difficulties just in movement and getting around. And although they may be able to get around independently for short distances, often for longer distances, they're needing wheelchairs. And some people, as they get older, can also have some swallowing issues. And so sometimes we see patients who ultimately are going to need a G-tube to be able to eat. So let's move on to the different causes of Lennox-Gastaut. And I think here we're actually making some really important strides. And I think no longer is it okay just to say your child has Lennox-Gastaut, but as you as parents and caregivers really need to ask, yes, but why, right? So do you really need to understand this is the syndrome, but what is the underlying cause? Because both of those things give you important information as to how to treat. So when we look at Lennox-Gastaut, there is this broad range of causes, and how likely we are to find a cause really depends on how carefully we look. And so here's this nice pie chart. You can see about a quarter of patients in the purple have what we call an acquired cause. So this might be due to some brain injury around the time of birth, maybe due to a traumatic brain injury in early life, usually early onset brain injury. And then we see in the green, fairly large piece of the pie, about 40% who have a developmental change in their brain, like a focal cortical dysplasia or other developmental change, or an inherited genetic condition. And I know Beth Shidley is here, and she's talking a lot about the different genes that can be associated with this. The red bar is the metabolic causes. Those are really uncommon, but important to recognize. That's problems with breaking down proteins and sugars and things like that. And some of those have specific treatments. And then we see still a fairly large piece of the pie, about a quarter to a third of cases are still of unknown onset. And so hopefully we will be able to make further strides. And as I had mentioned, it's not okay just to say Lennox-Gastaut, but we really want to know why do you have Lennox-Gastaut. So how do we investigate? So I think an MRI, and as MRIs are not created equally, I think it's important to get an MRI at an epilepsy center because the yield is quite a bit higher. Many kids with Lennox-Gastaut will have normal MRIs. But if we find a focal abnormality, like a focal cortical dysplasia or something like that, sometimes that can mean that the child can be a candidate for epilepsy surgery. And Scott Perry is going to be talking about that at one of the workshops. But if we can actually find a focal lesion, and if that child is a candidate, in fact, up to 83% of children can ultimately achieve seizure freedom. And if we do surgery early, we can often make a significant improvement in that child's development long term. So that's a really important thing to look for early on. And then here's some work from Beth Shidley's group, and they looked at genetic testing in the developmental and epileptic encephalopathies, of which Lennox-Gastaut is one of those. And again, you can see here, there's a really high yield for genetic testing. So depending on which test you do, and increasingly we are doing the RED test, which is the whole genome sequencing, but up to almost half of patients can be found to have an abnormality on whole genome sequencing. So genetic testing is really, really important. And sometimes you can find a gene that really gives guidance to your physician as to what is the best treatment. Some other studies, so metabolic studies, that was that small red sliver of the pie. So these are rare, but again, important to identify if they're there because some of them have very specific treatments. And then the other thing that sometimes you hear about, or is there any type of autoimmune process that could be causing this? That for Lennox-Gastaut is really rare. So that's not something that we generally would test for in most cases. So one of the questions then is, how do all of these different causes actually cause Lennox-Gastaut syndrome? And that's still a puzzle for us. So we still don't understand all of what this is. However, there is some evidence that Lennox-Gastaut is what we call a secondary network disease or a secondary network epilepsy. So what does the term network mean? What is a brain network? And so we know that brain cells are not just randomly connected to each other, right? We know that brain cells need to kind of work together in order to allow us to function. So for example, I'm holding this microphone. If somebody said, can you name what this is in your hand? Then I would need to look at that microphone. The information would go from my eyes to the back part of my brain, which is, well, it's not working. It's the back part of the brain anyways, to the occipital cortex. And then from there, it needs to go to another part of my brain that's a little bit forward from that, and that's what we call my visual association cortex, and that puts my, how do I interpret the information that's coming in from my eyes to know what it is that I'm seeing. And then once I figure out what it is that I'm seeing, then it needs to be transferred to my speech area of the brain so I can say, oh, that's a microphone, right? And so you have that network that needs to work together in order for me to do a pretty simple task, like name what it is that's in my hand. So we call that a brain network. And we know that there are different types of brain networks. So what we call the attention networks, this is the part of the networks, or the series of networks that are really activated when we're trying to learn something. So if you're trying to learn to cook, if you're trying to learn to ski, if you're trying to learn a different language, things like that, you turn on certain networks in your brain so you're really kind of primed to learn that information. So you can focus on that task. But there are also what we call default mode networks. And the default mode networks become active when you're not really doing very much. You're just kind of lying there and you're kind of thinking about life and you're putting some information together. You're a little unfocused, you're daydreaming, random thoughts. And so in most of us, when the attention networks are active, we want to turn off the default mode network because it's hard to pay attention to something and then daydream at the same time. And then when you're kind of, trying to make sense of life and daydreaming, we want to turn off those attention networks to try and process sort of the bigger part of the information, right? So if one of those networks is active, the other should be deactivated. Here's the problem. So in Lennox-Gastaut syndrome, and this has been looked at with the different types of discharge that we see in Lennox-Gastaut, there's actually co-activation of these networks. So the brain is being told to pay attention to something, but also it's okay to daydream about this. And so that really kind of messes up your ability to learn things. That leads to a breakdown in normal brain networks, and that has significant impact on learning. So to conclude, we now know that there are diagnostic criteria for Lennox-Gastaut syndrome, but early diagnosis is still quite challenging, and it takes time, often up to 2 years, for all of those boxes to be ticked. We also know that there are people who have Lennox-Gastaut-like syndrome who maybe don't tick all the boxes, but who have significant medical needs, and we cannot forget about them. We don't want to stop at a diagnosis of Lennox-Gastaut syndrome. That, in my mind, is still more of a, yes, it's a diagnosis, but in a way it's a bit more of a description. And so you really want to say Lennox-Gastaut due to this gene, or Lennox-Gastaut due to this change on the MRI. We know that Lennox-Gastaut disrupts normal brain network development, and that really leads to an impairment in their ability to learn. And I think one of the things that we don't know, and I think where we really need to focus more research, is we need to find better ways. So we have all of those infants who develop epilepsy, and at the other end, about 15 to 20% of them are going to have Lennox-Gastaut. Can we actually predict who those infants are that are going to develop Lennox-Gastaut? Is there sort of markers or what we call biomarkers that allow us to do that? And if we can predict, is there any way that we can prevent that, right? What is the best therapy to try and prevent that? And that's what we don't know right now. And I think the other thing we don't know is, and as Tracy had already alluded to, is we have a lot of therapies that are out there, right? There's a lot of FDA-approved medications for Lennox-Gastaut. None of them are highly effective, right? How many people here have, loved ones who are completely seizure-free? You don't get there, right? So we're looking at, a 30% reduction in seizures or a 40% reduction in seizures. So we do need better therapies in order to be able to treat these kids. So happy to answer any questions. And any questions that anyone has?
Do we have mic runners? Am I the mic runner? Oh, okay, here we go.
For those progressing to LGS, is there any thought of, is this something where we just did not get it controlled in time versus this was the direction you were going to go altogether?
Yeah, that's a really good question. I think it probably is a matter of both of those. So I think there is evidence that for infantile spasms, the longer that we wait to diagnose that, I think that does tend to portend a poorer outcome. But there are other cases where we know this is infantile spasms, where I think we're making a diagnosis and getting the child on treatment within a week, and yet it still progresses to Lennox-Gastaut. So I think there are certain things that we can do. I think probably more cases, unfortunately, in that latter group that, despite early diagnosis and despite aggressive treatment, things are still progressing. And that's frustrating. I'm sure for families, it's incredibly frustrating for clinicians as well.
Hi there. Question about research. Is there any research that speaks to medications that are used in LGS that is showing that some of the symptoms are actually, or that the medications are actually compounding some of the symptoms of LGS or contributing to some of the issues related to ID or, anything over time?
Yeah, so most of the research on medications are those that are done in what they call randomized placebo-controlled trials, and that's when the company is trying to get their medication licensed. I think the later studies, the more recent studies that have been done, one of the things that we're really seeing is the companies are really paying attention to the non-seizure symptoms as well, right? Looking at the development, looking at the impact on sleep, looking at the impact on sedation and quality of life. And so I think we've got better data from the more recently approved medications. Some of the older medications, it was still mostly focused on seizure control. Usually once a medication is actually approved, there's other than sort of what's called the long-term extension, where typically the company is doing that and providing medication and following the patients until the FDA approves the medication. Once it's FDA approved, there is less data that is being collected. I know that some companies have looked at sort of different quality of life, different impact on non-seizure outcomes after that, but most of the time there's little work actually being done on that once the medication is approved.
We have a question from online. They want to know, what are the mortality rates for LGS, both in infants and adults?
So we do know that there's been a number of studies that have looked at mortality rates in Lennox-Gastaut. There was one from Atlanta, there was one from the UK, and I believe one from Germany. And so certainly there are elevated mortality rates. The mortality for many patients is not necessarily seizure related, but it's due to neurodevelopmental deterioration or poor neurodevelopmental status. And so we know that a lot of children will have a higher risk of, for example, aspiration pneumonias or infections or things like that. And many children actually die as a result of those things as opposed to seizures. But again, we know that there also is higher rates of sudden unexpected death in epilepsy and death as a result of status epilepticus, or very rarely death as a result of, adverse effects to therapy. So yes, those rates are elevated.
Over here.
Yeah.
I'm right in front of you over here.
Okay, sorry. I see people waving their hands.
I had a question about LGS as a secondary network epilepsy. And your description of the default network and the attention networks being, I guess, on at the same time, I can see how that would cause learning impairment. Does it also contribute to the seizures themselves?
So we think it probably does, and the person who's really done a lot of research, and I think he's here, is Aaron Warren. I don't know if he's here in the room, but he is here, I think, tomorrow, and he will be talking about his work in that. So I would encourage you to follow up with him. It's really been his group with John Archer and the Australian group that has looked into that a lot.
Thank you.
Does anyone have the mic? Last question? Oh, one last question right here. And of course, Elaine is going to be here after, as well as Julie, so you can ask questions at the end as well.
So my daughter had the focal lesion on her brain. However, our neurologist said that most people have some kind of abnormality on their brain, and he said that that was not the cause of her infantile spasms or LGS. So is that not correct?
So it's really hard to comment on one specific case without sort of knowing all the information. I would say that one of the tricky things about LGS is even if you see sort of a focal abnormality, sometimes the EEG lies to us and it looks more diffuse. And there have been cases where they've resected that focal abnormality and the children have done very well. So I do think if there is, I would say that most children do not have focal cortical dysplasia seen on MRI. And I think if you saw that, then I would be certainly more concerned that that may be causal. But again, I think, the value in getting a second opinion as well. I think if you see that, reaching out to an epilepsy center that has a lot of experience in Lennox-Gastaut and a lot of experience in epilepsy surgery to really look carefully at the case would be helpful.